feel like we are late coming to the party, and you'll see from Andy's presentation that there are so many things for us to take from experiences over in the States, and my process of evolution of the local anaesthetic sinus surgery is very similar to Peter's, and for our own reasons we were put off this at different stages of our careers, but I feel like we're, as I say, late to the party, but definitely joining the party. Great to see so many familiar faces in the audience, and nearly full. I'd like to be optimistic, nearly full auditorium. Okay, so I'm going to talk about early intervention and EPOS guidelines. And when you look at the data, unfortunately, there's a real paucity. So everyone keeps referring to the EPOS guideline, but actually there isn't a lot in the EPOS guideline or published data to say when we should be operating on patients. My disclosure slide, so these lovely people help me to run my courses in Manchester. So what is the pathway for primary cases of chronic rhinosinusitis and chronic rhinosinusitis with polyps? According to the EPOS guideline, we're going to treat for 3 months, and we're going to choose one or all or a combination of medical treatment, so systemic anti-inflammatory treatment, corticosteroids, topical treatment, so varying doses of steroid topically, an antihistamine if there's a history of allergy with a positive skin prick test or a RAS test, and an antimicrobial. But this is all up for discussion at the moment in the context of current trials that are ongoing across the world, and certainly just about to take off in the UK. And if there's little or no improvement, the EPOS guideline then recommends radiology followed by surgery. But again, no timing. There's no time limit as to when these procedures should occur. With post-operative maintenance medical therapy after surgical intervention, the large majority of patients, thankfully, with a good phenotype, will improve and you'll be able to maintain their sinus cavities without a risk of recurrent disease. But in situations of failed medical therapy, okay, again we go back to this situation of how long should you wait before proceeding to surgery? What is reasonable? Is there a reasonable wait period? Should you wait? And is there any detriment to waiting? So in this sort of situation, so very little opacification in the right maxillary antrum, okay, but if that's associated with symptoms of recurrent acute sinusitis or symptoms of pressure, barotrauma on the right side, you treat with medical therapy, and if there's no improvement, at what point do you then decide to treat surgically? Okay? Are you that surgeon who's going to prescribe another course of therapy, and another course of therapy, and another course of therapy, or are you going to get on and do something surgically to try to settle that situation? Okay? Because if you don't, that sort of situation becomes this sort of situation. But if you look on the left side, okay, there's obviously something unusual going on, perhaps an eosinophilic mucus, so allergic fungal rhinosinusitis, fungal disease with bacterial infection. And then you start to move into an altered microbiome situation. Okay? So once you start getting into this situation, are you then missing the boat with being able to treat your patients effectively and bringing their episode of care to a close? Okay? So timing of surgery is key. So again, I'll go back to this paucity of data, and then I'll show you what my experience is with this group of patients and how I tend to manage my patients with sinus disease. A couple of papers, so back in 2015, that report that sinus surgery or sinus intervention do make a difference. They improve quality of life, that those interventions should occur within 12 months of making a decision to go ahead with surgery. Okay, so quality of life, disease progression also improves by intervening early. So again, the recommendations tend to be there. Okay? Anecdotally, those of us that do a lot of sinus surgery can report that patients do well if you intervene early, rather than just sitting on them and giving course after course after course of medical therapy. I think your phenotypes are going to fit a good, a bad, and an ugly situation. Okay? The primary is your good phenotype, so these are the patients without asthma, first episode of presentation, no underlying inflammatory disorder. Okay, primary cases where you expect your patients to do well. The bad situation is where those polyps recur. There's some sort of underlying inflammatory predisposition, and you need to work harder to keep these patients medically under control following their surgical intervention. And then the ugly group, unfortunately, we've all got some of these patients in our practice. These are the guys that you can never discharge, who have very unstable mucosa, who have inflammatory underlying disease that you need to work really very hard, perhaps with your immunologist and your respiratory physicians, to try to keep these patients under control to give them a decent quality of life. So what are recurrent cases? So again, now we're going back to my practice, okay? So recurrent cases are your failed maximal medical therapy, okay? And what is maximal medical therapy? Again, we talk about systemic corticosteroids. I guess if I asked all of you in the auditorium, your maximal medical therapy would be very different to my maximal medical therapy. I bet the three of us don't agree with what maximal medical therapy is, okay? So there is nothing to say what you should be giving and for what duration of treatment. Early radiology and revision surgery, I think, is good for disease burden. And post-operative maintenance medical therapy is very important, but as Peter said already, it needs patient buy-in. If your patients don't buy into this treatment period, it's a disease process with disease burden, whatever you do surgically is destined to fail, and that affects your figures then. Okay? So working hard with the patient. Your refractory cases or your recalcitrant cases, thankfully, is a fraction of the proportion of patients that I treat. But they're the ones you remember. They're the discharging cavities. You swab, you can't get to the bottom of the infection. You can't really settle down their cobblestone mucosa with whatever sort of medical treatment you're using. This is a difficult group of patients to treat. And we're moving in the right direction in terms of monoclonal antibody therapies, and I suspect that that's going to be the next big introduction for these patients in terms of bringing their mucosa under control. So what is recalcitrance or refractory sinusitis? Well, it means different things again to different people. I suspect for a lot of us, the recurrent polyposis would be termed recalcitrant. Okay? In my practice, this is a specific group of patients who've had maximal medical therapy and maximal surgical intervention, and they still then carry on discharging or have cavities that cause problems. So a very specific subset of patients that have recalcitrant sinus disease. And unfortunately, I think we contribute, not just us as secondary care physicians or tertiary care, but our primary care colleagues, unfortunately, I think contribute to this picture, and I'll elaborate on that later. So we have very poorly enforced primary care pathways. Peter's alluded to this already. Okay? Patients are given medical therapies, usually multiple use preparations, over-the-counter, non-prescription medications, delivered at suboptimal doses for suboptimal duration. Okay? So the recommendations would be 6 weeks of a suitable topical intranasal corticosteroid. How many of you will see patients who've had 2 weeks of treatment, or 1 week of treatment, or they've given up using it? So we start to sow the seeds of recalcitrance. And unfortunately, the same phenomenon then exists in secondary care. Okay? So again, I go back to this. I suspect our own protocols vary very much between individuals. Okay? So I think best practice is difficult to enforce, but we're unfortunately sowing the seeds of recalcitrance, the very thing that we're trying to avoid. So then we start to look more closely at immunology, then we start to look at vaccinations to help the patient to fight those infections themselves. You'll usually find there's a staphylococcal infection or a pseudomonal infection at that stage. Okay? Those are difficult to treat. You start to discuss these cases with your immunologist to see if there's some sort of unusual underlying predisposition to infections. You'll consider other types of medical therapies to try to settle mucosa down. But unfortunately, it usually ends up with there being some sort of uneasy compromise where the patient just ticks along. They come back to clinic 6 to 9, 12 months. How are you? You look in the nose, looks okay. We'll carry on as we are. Okay, but it's an uneasy compromise. So my early workup for sinus cases is allergy testing to exclude underlying inflammatory predisposition. If I see pus, I'll do an endoscope-assisted culture swab for CRS patients. We'll do a snot score and a triplanar CT scan, so very important. And you should have a plan for your patients as soon as they come to see you the first time. I don't think it's any good to keep offering medical treatment after medical treatment after medical treatment. This is my pathway for sinus disease, and I hope that we stop somewhere in the lower third of that without having to get to the middle third or the upper third. Okay? And Peter's shown already very, very elegantly that if you start to intervene with these patients earlier, perhaps under local anaesthetic, because we have time pressures, our operating theatre lists are very precious in the UK, so moving these patients into a different scenario, a different forum, hopefully we start to pick up these patients at a much earlier stage. There is good evidence, okay, that intervening early with balloon treatments or with sinus surgery, as Peter's presented already, the Chandra data, but also good balloon evidence that intervening early will reduce the longer term problems with sinus disease. So what we're, unfortunately, by not intervening, okay, so right maxillary sinus disease, and then offering treatments that are perhaps not considered gold standard, so perhaps a Caldwell look type procedure. Okay? And unfortunately what that then causes is recalcitrant, very unhealthy mucosa and a contracted antrum on that side. So I think we need to avoid these situations developing by having a plan in place and intervening early. And again, there is good clinical consensus published last year for balloon treatments. Okay? And the evidence that now exists is that patients should have an abnormal CT scan and they should have symptoms consistent with sinus disease, and that balloon interventions or limited sinus surgery as an early intervention helps to reduce disease progression. So in my own practice, okay, I'll take a history, an endoscopic evaluation, medical therapy as per EPOS guideline, but also my peers as well, so discussing and having these conversations with my peers. But the most important thing is that this will be time limited. Okay? I'll assess the patient at 4 weeks. Okay? So 4 weeks, they come back to clinic. If there's an improvement, I'll prolong treatment. If there's no improvement, that's the time then for them to have radiological investigation with a plan to move forward with surgical intervention as soon as possible. So this is how I tend to keep my patients under control and how I reduce the risk of refractory or recalcitrant disease. So with a view to improving quality of life and preventing recalcitrance. And I don't think there's a role for course after course after course of medical therapy showing no benefit whatsoever, but just ultimately delaying what you should be doing at a much earlier stage. So, in conclusion, recurrent chronic rhinosinusitis or recalcitrant chronic rhinosinusitis is not a well-defined entity, rather a clinical catch-all bag of terminology. I think it's a disaster, but in the majority of cases should be avoidable if you manage your practice in a time-limited fashion. There's a large variation in practice due to surgeons' training, their experience in sinus surgery, their aggression or radicality, I don't like that word aggression, but aggressive sinus surgery, comprehensive sinus surgery, and standards of post-operative care, which will vary amongst us all. I go back to this time-limited phenomenon with maximal medical therapy, and it's important for discouraging recalcitrance, and then go ahead with your triplanar CT scan, and then sinus-specific intervention. So treat every sinus that's involved, otherwise it acts as a reservoir for ongoing disease. Very important. And perform your surgery expediently. I'm not the best at that because of waiting list pressures in the UK, but the ambition is there to perform surgery expediently and then optimise post-operative medical anti-inflammatory care. Very important to get patients to buy into this concept. Thank you.
Greetings from Augusta, Georgia. It's wonderful to be here at this most excellent Congress. And as Peter and Raj have most eloquently described, it's critical for timely intervention for our chronic sinusitis patients. And this is a topic that I'm very passionate about, and I'm excited to share with you our approach to timely intervention in an ambulatory setting with the most minimally invasive approach and procedures that are possible. And the great results, the many advantages that we've seen in taking that approach. And then I'll conclude with something very important to the success of that approach, and that is a good, solid, repeatable sedation and anesthesia protocol. And after I'm finished, the three of us will be here to have discussion, to answer questions, so please stay around, and anything that comes to mind, if you want to challenge us or share your own experience or ask questions, let's do that. We would welcome that. So we treat a number of conditions in an ambulatory setting, certainly CRS, but also nasal obstruction, eustachian tube dysfunction, and chronic rhinitis. This is my disclosure. Just a little about my journey. I started using balloon dilation in sinus patients about 9 years ago, and I continue to use that when I am in the OR, but more and more I treat nearly all my patients in an ambulatory setting. Started that move to treating patients there in January of 2012, and also started my pediatric treatment using balloon dilation. And initially I still did quite a bit in the OR using FES, and then have transitioned to now where nearly all of my initial treatments for my CRS patients are in the ambulatory setting, using balloon sinus dilation and other